Hello, good evening, dear students. I am Dr. Ruchi Raj, your original guru for Prosthodontics. Very warm good evening to all of you. Today we are gathered to discuss the INI Power Grant 2 questions pertaining to the subject of Prostho, and I'll be available on the Telegram group whenever you post or any queries or questions. So without wasting any further time, let us start with the first question. The first question says peripheral flange is seen in which implant form? Options are option number A, we're just waiting for some technical confirmations. सुनील जी स्टार्ट करें. सेशन लाइव है. Okay, students, if you are live and you are able to see me, just put a message in our Telegram group so that I have a go ahead and we begin with our class over here. I'm waiting for your messages in our Telegram group. Okay, so let us begin with the discussions. Peripheral flange is seen in which implant form? That is the first question. A. Subperiosteal implant. B. Extraoral implant. C. Disc form of implant. And D. Root form implant. Now, dental implants generally, if you want to classify, they are classified as endosteal, right? So, I'm waiting for your messages in the group. Yes, okay. So I have a confirmation that I'm audible. Great. So the first question, dental implants can be classified as endosteal. This means that implant is within the bone. Then, so if you have a bone structure like this, the implant would be within the bone like this. Fine. That is the first one. Second is transosteal. Transosteal means through and through engagement, wide cortical engagement, if you want to say. So, implant is this is your bone, the implant would be engaging through and through like this. Fine. Third variety is called as subperiosteal. These are implants that lie or sit over the bone, right? And the fourth variety is called as mucosal implants. As the name suggests, they are in mucosa. Fine. I think there is a lag in the video somewhere. I'll just wait so that it settles. Fine. So now this is the basic classification of your implants. Can you guess what the correct answer of question number one is? A peripheral flange is seen in which implant form? Subperiosteal, extraoral, disc shape, or a root form implant? Can you just take a guess over here, students? Anyone? Can you take a guess over here? We have a lot of students actually online also right now. I'll encourage all of you to keep this as an interactive session. Can you just take a simple guess? What could be the answer, or what have you attempted in this particular question of your Power GT? A peripheral flange is seen in which implant form? Subperiosteal? Okay, no. Subperiosteal is not the correct answer. The correct answer to this question is your extraoral implant, option number B. Now, when we further classify endosteal implants, they are root form, blade form, and disc form. Right? So, this are actually endosteal implants. Now, you may ask what are extraoral implants? So, extraoral implants are your maxillofacial implants. And in a subperiosteal implant, which is like a maxillofacial implant, I have actually uh, stored one image and I can show it up to you all. I hope you are able to see that over here. So if you can visualize and see this peripheral flange that is surrounding the hex of your implant, that is a peripheral flange of 5 to 6 millimeters that are kept in your maxillofacial implants. Reason is that it helps in the initial stability of the implant and it prevents further penetration or seating of the implant into different compartments that may be there underneath. So that is the correct answer. Option number A, that is your extraoral implant. I hope you all have understood this. Are there any queries or any questions that you want for me to elaborate or answer? Question number 1, peripheral flange is seen in which implant form? Anyone? Any queries, any questions? Okay, I see that there are no queries or questions. So we'll move ahead with the second one. The second question is pertaining to the soft palate form. Most favorable soft palatal form for denture is what? When soft palate makes an angle of 70, here it is 70 degrees. This is actually some mistake with PowerPoint. Then a soft palate making an angle of 45 degrees. Soft palate is horizontal with minimal muscular activity and none of the above. So the correct answer here is soft palate being horizontal with minimal muscular activity. Now there are direct lines in your Zab Bolender or your vouchers pertaining to this, that class 1 of soft palate, which is horizontal, is most favorable for CD retention. This class 1 soft palate has an angle of 10 degrees, right? Class 2 has an angle of 45 degrees. Class 3 has an angle of 70 degrees. Class 3 will have the poorest retention of all of them, right? Usually, if you see, class 1 is associated with a U-shaped palate, and class 3 is usually seen with a V-shaped palette. So these are just some extra points around this particular topic which you can remember. Questions can be spun from these extra points also and can be asked in your exams. So pretty simple question. Yes, your answer is correct. Answer is option number C. Now, force of retention between maxillary denture and saliva that is created by saliva is what? The correct answer here is options are A, adhesive, B, cohesive, C, interfacial surface tension, D, surface adherence. Now we all know there are 5 basic factors that affect the retention of a prosthesis. As we have learned the definition of retention, it is that quality inherent in a prosthesis that will prevent the dislodgement of the denture against the forces of gravity, adhesiveness of food, and any forces that will try to dislodge the denture from the denture bearing area. Basically, anything that will prevent the maxillary denture from falling down or the mandibular denture from lifting upwards are forces that help in retention of a prosthesis. Generally, there are 5 forces that are there. In those 5 forces, one of them is 5 factors. In one of them is a factor which is called as a physical factor. In these physical factors, we have adhesion, cohesion, interfacial surface tension, and all of them. Now, we all know adhesion is attraction between like molecules, unlike molecules. Cohesion is attraction between like molecules, and What is interfacial surface tension? That is the answer to this question, because saliva has been mentioned here and it is specifically saying force that is created by saliva. Now, when you take two glass slabs against each other and add a drop of water, and how they stick to each other, and you're not able to even twist or separate them from each other, that force which is present between both of those flat surfaces because of the fluid is called as interfacial surface tension. Between two surfaces, when there is a thin film of fluid that is evenly spread with very good wettability, where the surface tension is less, so the wettability is more, and it is formed as a thin film between the two surfaces, it will add to forces of attraction and both surfaces stay in intimate contact with each other. In a present situation, the two surfaces are palate and your maxillary denture, and the thin film is formed by saliva. Since our question mentions the force of retention that is created by saliva, that force is interfacial surface tension. I hope you are able to solve this question. Slightly tricky, but still, I would say an easy question if you have understood the concepts of retention. Now, question number 4. For an immediate denture, why is the transparent acrylic template made? Is it for socket healing? Is it for trimming the jagged bone margins? It is for impression making or for socket conditioning. Anyone, what should be the answer? Or why have you not, I would say, okay, so we have a query from one of our students asking why in the previous question. Let us first take up that before solving the new MCQ. Why is it not adhesive? Now, very simply, I'll tell you why is it not adhesive. The reason the force is not adhesive or the answer is not adhesive is because that it has been specifically mentioned the force that is created by saliva or the factor that is because of saliva. So, although you may want to take up adhesive forces as the answer, but only saliva is not responsible for adhesion. It is between maxillary denture and your saliva and the force that is created by saliva. Very specifically, it has been asked. If you call adhesion, it is the both factors are responsible for it, denture as well as saliva. But for your interfacial surface tension, the thin film of fluid is responsible for it. So that is why it is a better answer. It is a slightly tricky question, but that is the correct answer for it. I would advise you to go for answer interfacial surface tension, although you're mentioning that a particular answer has been given in some other question bank. But this is the correct answer according to me. And if you, I think I have verified it with standard textbooks for the same. However, I leave it to the liberty of our students sometimes to decide where or what do they trust and what do they go want to with or go further with. But my answer here would be interfacial tension. That is my choice of answer if I were to attempt for it. So I hope that is that satisfies your doubt. Is that a go ahead to move to the next question? Right. So question number 4, in immediate denture, why is the transparent acrylic template made? The transparent acrylic template is made for the purpose of trimming the jagged bone margins. Basically, you are making something which is called as a surgical template. And this surgical template is thin and transparent because it is made up of your clear acrylic. It duplicates the tissue surface of the immediate denture and acts like a surgical guide for shaping the alveolar process post extraction. So, as we all are aware, in an immediate denture, the final extraction is done on the day of insertion of the prosthesis. A surgical template will mimic or will copy, or rather will be a duplicate of the tissue surface of the immediate denture that you have made, and then that particular can be tried to seat inside the patient's mouth. Now, through the transparency, you can see which jagged bone margins of the extraction socket are interfering with the seating of the denture. You can then trim them off with a bone rounder or even a burr, and that will help you through the insertion process of immediate denture. So the correct answer is option number B for trimming jagged bone margins. Excellent. Now, question number 5. Most common cause of an over contoured restoration is very straightforward and something that we have learned through principles of tooth preparation with diagrams also. An insufficient axial reduction. Axial means the vertical walls of the tooth. An insufficient axial reduction, or generally an underprepared tooth, leads to a laboratory error of an inevitable over contoured crown. Right? So, very simple, very straightforward question. Something that we have seen through FPD is underprepared tooth is the reason for an over contoured restoration. Now, you may think why option C and D are not the answers. C and D are obvious mistakes that can be conducted by someone. Excess bulk will always lead to a larger tooth or a larger or a bulkier crown, but we are talking about the contour, this particular contour of a crown. So this bulk or this contour of the crown is more when you have an underprepared tooth. Excess bulk addition or an oversized die will lead to a more than larger size of a crown rather than having just an over contoured crown. Besides, very specifically, it has been mentioned in your textbook that underprepared tooth is the reason of an over contoured crown. So that is the answer. Now, again, a simple question from RPD, but something that is very important concept that we have understood. Joint between mandibular RPD, major and minor connector, always is a butt joint. Junction is always a strong butt joint, that is a 90-degree angle. So you have a strong 90-degree angle, but you must remember that the junctions are always curved like this. They are never stiff 90-degree or not a sharp 90-degree, but they are always curved. The reason for it is that take your ortho wire and bend it at 90-degree, try to mold it and it will break because the sharp bend will create a point of stress concentration that can be broken easily. Similarly, the same phenomenon happens with all metals or alloys. In a cast partial denture, if you have a sharp 90-degree angle as a joint between major and minor connector, it will become a point of stress concentration and lead to eventual fracture of your prosthesis. So just remember that you have a strong 90-degree joint with curvature. It is curved so that there are no points of stress concentration. Now, all of the Pontic designs mentioned below have good aesthetic profile, except, always remember the word except. So, does modified ridge lap have excellent profile? Yes. Ovate has? Yes. Between saddle and conical, although we do not advise saddle Pontic clinically, straightforward from your textbook of Rosenstiel, in the table of Pontics, it is written saddle not indicated. But it has an advantage of good aesthetics because of the overlap. So the only odd one out over here is conical pontic. Reason being that conical pontic has a convex tissue surface which contacts your ridge at a single point. without any pressure, right? This pontic is very easy to clean and maintain and is indicated in mandibular, where in mandibular posteriors, right? So because of its appearance, it has poor aesthetics. Keeping an eye on our group here, but I see there is very poor participation actually from our students. I'll encourage all of you to be interactive in our groups for the time that you're spending during this discussion so that you and I both can help each other out, solve some doubts, and understand some new concepts of prosto. Question number 8. A very, I would say, age old question, but still relevant in today's time. Shade selection is done within how many times to avoid fatigue? The correct answer is 5 seconds. Now, the reference comes from 4th edition of Sturdivant, where it mentions that make the selection of shade as rapidly as possible, since there are some physiological limitations in the color receptors of the eye. So, because of this, you have to do it within the 5 seconds. Now, obviously, in one go, we may not be able to do it. So, if more time is required, then the eye should be rested on blue or violet, and then you can redo it again. So the eye, after staring at a particular shade for more than 5 seconds, becomes accustomed as well as biased. So your correct shade may actually become wrong, which is why shade selection may become wrong, which is why this phenomenon is known as hue sensitivity. And you should do it between the time of 10 a.m. and 2 p.m. That is the correct direct sunlight or broad day sunlight is the correct light for your shade selection. Now, question number 9. Shunting effect occurs in complete denture when? When the occlusal plane is lower in molar area, if the occlusal plane is lower in the incisor area, if it is lower in incisor as well as molar, and when the patient has poor muscular coordination. Now, first, you need to understand what shunting is. When the occlusal plane is not parallel to your ala tragus line and it is inclined in any one direction, either forwards or even backwards also. However, the description of shunting is very specifically mentioned in your vouchers when the occlusal plane is lower in the incisor area. So, we will take up that as the answer. But to solve your question is, when your occlusal plane is lower in the, not particularly this much, but say when it is lower in the incisor area in comparison to the molar more, you will have unforward, I would say, something that you would not prefer. So, unpreferred movement, forward movement very specifically of the denture, specifically your lower denture. Similarly, it is also said that when it is tipped posteriorly like this, even then you would see some shunting effect, primarily seen when it is lower in the incisor area, and it will lead to actually loss of retention of the denture. So, shunting lower in incisor area. Option number C creates the maximum confusion here. So I would like to add that I believe if it was written, if the occlusal plane is lower in molar or incisor area, then I would go for option number C. When it is lower in both areas simultaneously, then there is no shunting effect. So correct answer here is that option number B, which is lower in the incisor area. If the plane is too high, there is a chance of posterior plane is too high, anterior is low, chances of denture slipping out of the mouth. Now, coming to question number 10, non-anatomic teeth are indicated primarily in what? Answer is flat ridge. It is a straightforward line taken from Winkler where it is written flat ridge is the single best indication for the use of non-anatomic teeth. So considering a line that has been picked up from your textbook, answer is option number A, flat ridge. Reason is that by non-anatomic teeth, you want to reduce lateral forces, right? So that is the reason for it. So answer is flat ridge. Now, denture fabrication for patient with Kennedy class 2 mod 1 for mandibular arch. Opposing arch is intact. This is something that we discussed in the last class of our live sessions just about a day back. When there is an intact maxillary arch and you have a class 2 situation, the description of modification space has not been mentioned. What occlusion is to be followed? Is it canine guided? Is it unilateral balanced occlusion? Is it bilateral balanced? Or is it canine or unilateral balanced depending on total number of missing teeth? The correct answer here would be option number D. Now we'll eliminate one by one all of them. Since you have only a unilateral distal extension case because it is a Kennedy class 2 plus opposing arch is an intact natural arch, bilateral balanced goes out of the option. Now, if the restoration has to re-establish the lateral guidance and canine protected articulation is preferred when natural canines would be present. If, however, the span of the modification area is more, the teeth have been worn out, then in that case you would prefer a unilateral balanced occlusion. But nothing has been mentioned about either the span of the edentulous area or the number of missing tooth. That is why the correct answer would be canine guided or unilaterally balanced depending on the total number of missing teeth. Briefly, if I have to tell you, I need to just explain you some points about occlusion. Generally, the brunt of centric forces are taken by posterior teeth as the centric stops. And when we move from centric occlusion to protrusion or lateral movement, that is guided by your anteriors and your canines. Now, when in lateral movements, if the canine tip comes in contact and disoccludes all of the teeth, that is called as canine guided occlusion. That is seen in young individuals. Over a period of time, when the tip of the canine wears off, and then when you go into laterotrusion, that is excursive movement, and you see that all the teeth are coming in contact, that is a group function kind of an occlusion, right? So that is the basic difference between both of them. Now, very straightforward fact-based question. Stain removing commercial denture cleanser contains what? Soda ash, sodium perborate, potassium perborate, or sodium hypochlorite. Remember, hypo is not used in these cases. It is always sodium perborate. And we all are aware, denture cleansers contain always oxidizing agents. And examples of these are, one is your sodium perborate monohydrate, and second of it is potassium peroxymonosulfate. Remember both of the name. These are oxidizing agents. They will be acting like bleaching agents, removing the discoloration and stains on the denture. When the sodium perborate is added, it produces hydrogen peroxide, and that will lead to cleaning of the denture, right? So when it is placed in water, there is effervescence that leads to dislodgement of the debris and cleaning of denture. And last question, salts of Gondres is a type of what? Is it a flux, adhesive, etchant, or an accelerator? Now, questions like these are very tricky. If you're not read, you would not be able to make out what it is, right? So, answer is it is a denture adhesive. This is a very long lasting, less soluble denture adhesive. It is a repeat question, and not, I have not seen it in recent papers, but can come up in any exam. So never make mistakes in such questions. And this brings us to the end of our Power GT2 discussion. You can also look at Advanced Plus version 2 features, pre-booking for which is now open. As you may be aware, and some of you have already enrolled, we have pre-recorded videos, question banks, test series, and a lot of things. So with this, I bring an end to the Power GT2 Prostho discussion. I am added in all of your groups, your 2024 group or your general DBMCI MDS group. There are any doubts, queries, questions, feedbacks, or suggestions, you're most welcome to send them to me. That is Dr. Ruchi, me, your mentor for prosthodontics, signing off, closing this session. Have a lovely Sunday evening, all of you.